So let's get started. I just wanted to just make an announcement that the next visiting professorship and Controversies 5 p.m. is going to be on Monday, June 3rd. We're very excited to have Dr. Rabinovich, who's a world famous authority on pulmonary hypertension, who will be a visiting professor that day. Today we had really a privilege to have one of the leading people in heart failure in the country as our visiting professor, and you'll hear more about it in a little bit. Today's topic was actually very, very interesting because it's a novel, unique concept, which is very, very important as we talk about patients from many entry points of going to heart failure. The topic was very difficult, and luckily we had a fellow who was able to up to task. Mike Healy will give us an overview of the topic.
All right, just a quick word. So across the United States and the world, the burden of treating patients with heart failure remains great and poses significant clinical and economic challenges to our healthcare system. While the mechanisms of injury seen in heart failure are multifactorial, and myocardial infarction and infiltrative and inflammatory disorders, toxic insults, and valvular disease, idiopathic cardiomyopathy, to name a few, interestingly, they share a common pathway in terms of disease progression. As a compensatory mechanism in response to failing cardiac output and mechanical stress, systemic neurohormonal activation and alterations of myocardial biology result in a pathologic and progressive remodeling process of the left ventricle, most notable by chamber dilation. Over the last 20 years, remarkable advances in heart failure therapies, both medical and device-mediated, have led to tangible improvements in morbidity and mortality. But interestingly, these very therapies have also been shown to partially reverse the pathologic remodeling process that is characteristic of heart failure progression and shared amongst many types of systolic heart failure. Though rare, when the reversal of the remodeling process does occur, a minority of patients may even go on to experience complete clinical resolution of heart failure. This phenomenon has collectively been referred to as myocardial recovery. While the exact mechanisms of myocardial recovery remain undiscovered, research has thus far taught us that the phenomenon is associated with a complex interplay of hemodynamic unloading, cessation of neurohormonal derangements and cytokine derangements, normalization of the biology of the myocardium, and its gene expression. Furthermore, we have learned that not only does myocardial recovery happen and it's real, but it can occur even in the sickest of hearts. In fact, the term myocardial recovery was first used to describe the improvements in myocardial function that were observed in the minority of patients with end-stage heart failure treated with LVADs, who then subsequently recovered their ejection fraction and had their LVADs explanted. The remarkable observation of myocardial recovery, specifically in the context of LVADs, but also with other heart failure therapies, has engendered great excitement for the future ways in which we could manage patients. Research advances in the mechanistic understanding of this phenomenon, as well as further identifying the mechanisms of myocardial injuries that commonly lead to heart failure, could improve our ability to prognosticate which patients will respond best to our therapies currently available, and thus affect our treatment selection as well as the timing of our interventions. But even more, such insights could eventually lead to the development of novel, precision-based therapies that could reverse rather than only attenuate the disease process. However, despite the observations of myocardial recovery and the excitement it engenders, many debatable questions remain. Is myocardial recovery only possible in a minority of patients being treated with heart failure? Here, our clinical data is conflicting. When you look at the INTERMACS registry on advanced heart failure, it suggests that only around 1% of all patients receiving LVAD therapy will go on to experience myocardial recovery. Meanwhile, single-center prospective studies tell a different story, such as RESTAGE HF, which recently was presented at ISHLT, that we made use of a priori bridge to recovery LVAD protocols and showed much higher recovery rates amongst patients. If the latter is true, some might ask, are LVADs presently being underutilized as a therapy to achieve myocardial recovery? Another question is, why do certain patients respond to therapy and experience reverse cardiac remodeling, while others may respond only partially or not so at all? Current data has shown that patients with ischemic cardiomyopathies and high burdens of scar are less likely to recover compared to younger patients who are non-ischemic. However, beyond this, our understanding of how the inciting and ongoing mechanisms of injury leading to heart failure affect the likelihood to remodel and recover is limited. Prediction tools for myocardial recovery, the use of imaging and biomarkers to phenotype and prognosticate various forms of systolic heart failure are still in their infancy. And furthermore, we may ask, even when patients do achieve myocardial recovery, are they truly cured of heart failure? Or are they simply in a state of remission where they are vulnerable to decompensating when restressed? While debate continues, the recent TREAD-HF trial has taught us that withdrawing medical therapy in patients who do recover their ejection fraction unfortunately results in increased risk for heart failure relapse at 6 months. So despite the exciting prospects of myocardial recovery, we are likely only seeing the tip of the iceberg. Our limited understanding of the biological determinants at play, as well as the inconsistencies in clinical practice, remain a challenge. And until future investigations can address these and many other questions, our future ability to leverage the phenomenon of myocardial recovery as a clinical treatment will likely remain controversial.
So again, a very complex, very important topic, reviewed very well. Let me take the privilege and the honor of just replacing Dr. Fuster for this next part of the program. He apologizes. He's not here. He had to go for an emergency outside of the hospital, but he asked me to take the honor of introducing Dr. Mehra more formally. Dr. Mehra is the first William Harvey Distinguished Chair in Advanced Cardiovascular Medicine at Harvard Medical School and serves as the Medical Director of the Heart and Vascular Center and Executive Director for the Center for Advanced Heart Disease at Brigham and Women's Hospital. Additionally, he's the editor of the Journal of Heart and Lung Transplantation, which is the leading journal in the field. He is the past president of the International Society of Heart and Lung Transplantation and the past president of the Heart Failure Society of America. He has over 500 scholarly papers. He initially went to medical school and did his Masters of Art first in India and then Masters of Art at more recently in Health and Economics and Management, London School of Economics. He did his internship and residency, Mount Carmel Medical Center in Ohio, was chief resident there, did a fellowship in cardiology in Oxnard Clinic in New Orleans. He stayed on at Louisiana State as an assistant professor. He then went to University of Maryland, where he was professor and head of cardiology there until 2012, when he became professor and executive director of the Center for Advanced Heart Disease at Harvard Medical School. He currently, as I said, is editor-in-chief since 2009, 10 years, the Journal of Heart and Lung Transplantation. He's on the editorial board of almost all of the prestigious journals in cardiology. Importantly, he's won outstanding teacher awards at every institution that he's been at. He has written seminal papers which lead the field in heart failure. Most recently, his New England Journal of Medicine articles on HeartMate 3 in the Momentum 3 trial were very, very important in moving the field forward, both technologically and clinically. He has been a mentor to numerous people in position of leading their programs in transplant who look to him for guidance and direction. And most importantly, he was a mentor of Dr. Lala, who we're very proud to have. I think that I can't talk about heart failure at Mount Sinai without acknowledging the role that Sean Pinney himself has taken, starting almost literally from scratch, almost from nothing, to make it one of the most important programs in the country, and being able to lead not only here at Mount Sinai, but all the institutions affiliated with Mount Sinai, and being able to accrue outstanding faculty in every aspect of heart failure. The heart failure service has grown here tremendously, and people rely on his sage wisdom to take care of patients on a day-to-day basis and long-term prognosis. Dr. Pinney is going to moderate today's panel discussion, and I'll briefly introduce the rest of the panel after I have Dr. Mehra come up. This is a plaque with Dr. Pinney. It says, "The faculty and fellows of the Zena and Michael Wiener Cardiovascular Institute and the Marie Josie and Henry Kravis Center for Cardiovascular Health express appreciation to Mandy Mehra for outstanding teaching wisdom and expertise as the Ananda L. Sharma Visiting Professor and the Simon Dack MD Memorial Lecturer, May 20th, 2019. Let me just take a picture of the three of them.
Thank you very much, Marty, for those very kind words. If I could just invite the panelists up. And we have joining us today, so obviously Dr. Mehra, Dr. Anyanwu, Dr. Lala, Dr. Steve Liao, Dr. Donna Mancini, Dr. Noah Moss, and of course, Dr. Michael Healy. And so I just want to start off by congratulating Michael for really putting together a fantastic monograph on what is a very technical and some would argue somewhat esoteric topic, and I thought he did so very brilliantly and presented it very concisely and yet very completely at the same time, so very, very well done. This is really a special day for me, and I know for our heart failure group, to invite Dr. Mehra here. I remember many years ago being a first-year attending my very first Heart Failure Society meeting, and I went to a research session, and there was this guy, and he was standing there taking questions from the audience, getting a lot of feedback, and very quickly synthesizing it, giving it back, summarizing it, writing it down on a whiteboard. And I remember turning to the person next to me, like, who is this guy? And they're like, oh, that's Dr. Mehra. That's Mandeep Mehra. And so at the time, Dr. Mehra was at Oxner. Very soon after that, had moved to University of Maryland, where he really transformed the cardiology division there, and then got recruited to the Brigham and Women's Hospital, where he has done the same at that very storied institution. Dr. Goldman mentioned that Dr. Mehra is editor-in-chief of the Journal of Heart-Lung Transplant for 10 years, which is really a terrific tenure as editor. And Dr. Mehra has set the bar extremely high, has really transformed that journal, significantly brought up its impact factor, and has transformed it into one of the leading, not heart failure journals, but one of the leading cardiovascular journals. So congratulations for doing that. So let me jump into tonight's panel. We're going to talk about myocardial recovery. And just to kind of put this into context, I thought I would start off with this slide. So we heard that Dr. Mehra led the Momentum 3 trial. This was the trial with the HeartMate 3, which is cutting-edge technology. You heard about it at lunchtime today. This is the very best technology that we have right now, and this was the trial that was done across the country, leading centers of ventricular assist technology and care. And so these are competing outcome graphs for the two arms of the trial, the centrifugal flow pump versus the axial flow pump. And I want to draw your attention to the rates of myocardial recovery. Now, those of you in the back row are squinting because you can't see the green line, and that's because it's completely contiguous with the x-axis. And that's because the rate of recovery leading to explantation of the pump, or sometimes what's called deactivating or decommissioning the pump, where you leave the pump in place but you disconnect it and either staple or do something to occlude the outflow graft, the rates of recovery were 1%. So this trial was the largest trial of mechanical circulatory support in heart failure of all time. 1,028 patients enrolled and randomized. 1% recovered. So to put this into context, we're talking about 10 patients Every year, we implant about 2,500, maybe 3,000 left ventricular assist devices in the country. And if 1% of people recover, we're talking about 30 patients who recover enough to have their devices explanted. So before we can think about what we're talking about myocardial recovery, I think it's important for us to understand what we mean by myocardial remodeling, left ventricular adverse myocardial remodeling. So in the middle of this slide here is a normal cardiac myocyte. You can see it here in scanning electron microscopy. And over here, what you can see are the myocytes and also the extracellular fibers. Now, there are two types of myocardial remodeling. There's that what we see with a pressure overloaded state where sarcomeres are laid down in parallel, and you see a nice thick myocyte here, myocardial fibril here, and also a very dense extracellular matrix. Now, in dilated cardiomyopathy, and that's what we're going to be talking about today, or forms of dilated cardiomyopathy, either ischemic or non-ischemic, there is an increase in fiber length, which is greater than, or the volume, increase in volume is greater than the increase in myocardial mass. That's why we call it eccentric remodeling. But here the sarcomeres are laid down in parallel, in series, and as a result of that, you get elongation of the fiber. But there's also disruption of the extracellular matrix. Now, I'm going to ask that you keep these pictures in mind as we talk about recovery, because we're going to talk a lot about geometric recovery. But is there really truly recovery? Does the heart ever really go back to normal? And that's one of the questions we'll explore as a panel. Now, one of the things that we know is that the best way to improve heart failure outcomes are to give guideline-directed medical therapy. And all these therapies have something in common, and that is that they all affect reverse remodeling of the left ventricle. They either abrogate or slow down that process of remodeling, or in some cases actually reverse it. However, there is a disconnect between patients who are eligible for these therapies and the patients who actually receive them. So if you just draw your attention to the areas in red, this is the opportunity. The opportunity to increase ACE inhibitors, ARBs, beta blockers, mineralocorticoid receptor antagonists like spironolactone, isordil, hydralazine, and nitrates in those patients with who self-identify as being African American, CRT and ICD therapy. So now this is a really interesting thought experiment by Greg Fonerow, kind of like a back-of-the-envelope calculation, which is to say, look, if we apply or if we identify or count the eligible patients who are not being treated, and imagine that they were optimally treated, and then we look at the number of patients needed to treat in order to save a life, and we multiply those two together, we can add up the number of lives that we can save every year in the United States. And that number is close to 68,000. So as we think about talking about myocardial recovery, which affects dozens of patients every year, what we're really missing is that underpinning, that huge part of the iceberg where we're talking about tens of thousands of lives that can be saved just by applying the therapies that we already have. And if you extend this idea, this concept, to just switching from an ACE inhibitor to an ARNI, this sacubitril valsartan, an additional 28,000 lives can be saved every year. All of this actually is leading to a question, and Dr. Mehra, so I'll kick it off with you. There's a tremendous disconnect between what is available and what is delivered. Why are we not living up to the promise? Why is there such a gap in performance like this with prescribing heart failure medicines?
Well, you know, it's a complex question that you pose. It's an important question. I mean, look at the prescription rates of statins after myocardial infarction. Do you know the average duration of statin use after myocardial infarction in the U.S.?
6 months.
3. Yeah, very close. So I think this whole issue really surrounds a concept of post-trial implementation science, and there are many challenges to how we think through what the knowledge barriers are and what the access barriers are to this. And typically the answer is somewhere in between these two constructs of the knowledge barriers, that is, do we have sufficient awareness in identifying the knowledge base of how to use these therapies, or the access barriers, and do we have access to these therapies? For example, at the time this paper was written, the general guideline mandated prescription rates of ARNIs were 2.4% in the United States. 2.4% of actual targeted patients were being prescribed this, largely because the costs were too much. So there are many challenges to this. So I think it's multifactorial. I think it's socioeconomic. I think it's knowledge, awareness-based. And I think that in general, I also suspect that there is one big challenge that I'd love for the other panelists to weigh in on, and that is this dissociation between prognosis and symptoms. So what I mean by that is the fact that shown here on this slide is the potential for lives to be saved. But there is a huge disconnect in the application of therapies vis-a-vis whether we are using them to save lives versus improve symptoms and the quality of life of patients. And the big inertia that I see in the community is that when a patient's clinical status is reasonably affirmed to be stable, they say, oh, well, I think we're done. And they do not go to the next step of saying, well, if we have reduced the symptom burden of this patient, what are we going to do with also ameliorating the negative prognosis of the disease? And I think that's a huge educational gap. So I'll just turn it over to others to comment on that as well.
So Donna, what do you think?
I think there are a lot of different factors that impact the optimal use of medical therapy. They involve insurance, they involve cost, they involve a variety of providers that each patient is seeing now rather than a consistent provider. So I think there are a lot of factors.
Yeah, Dr. Lala.
I would just add, I think the fact that we see peaks and valleys along the journey of a heart failure patient can be very deceptive, both to the clinician and to the patient. Because once they feel better, the notion or the tendency is, okay, well, I don't need the meds anymore because I'm feeling better. When in fact, it's you're feeling better because you were taking the meds. And then they decompensate again, recognize the need for it, are on it for a short period of time, and then may discontinue it. So I think the fact that we deal with those peaks and valleys make it a little bit more challenging as well.
Yeah, I think that's a great point, and I also would just extend that a little bit by saying that so much of what we're going to talk about reversing is still there presently in patients with heart failure, but we can't measure it. You can't measure the alterations in gene expression profile. You can't measure the differences in microRNA expression. You can't look at the ultrastructural changes that are occurring at the level of the myocyte or at the tissue level, although our imaging is getting a little bit better now with cardiac MR and things like that. And I think if we had those, even going beyond just biomarkers, but could measure these processes, then that would remind us of the need to continue to treat aggressively with neurohormonal antagonists. Okay, so let's move on. And so I thought that probably more than any other topic, this particularly lends itself to a case presentation. So we'll talk about one of my patients. So this is MC. She's a 31-year-old woman with postpartum cardiomyopathy, and she presented really weeks after delivery with symptoms of heart failure, pulmonary edema. She was hospitalized recurrently out in the community, including a couple times needing IV milrinone. And she was discharged most recently on a life vest, and then she was referred to come here to Mount Sinai Hospital to be evaluated for an LVAD and for transplant. Now, all these symptoms are occurring within, like I said, weeks of delivering her child, and we saw her about 3 months after delivery. So, Steve, maybe you could take a look at this echo for us and just describe what you see.
So there's looks like biventricular systolic dysfunction with left greater than right. The LV appears to be dilated. It doesn't appear to have any segmentality to the hypocontractile state. It looks pretty global to me. Left atria and right atria also appear to be maybe a bit dilated overall, but hard to know without actually measuring.
Yeah, so completely agree. So they read this out as the left ventricle end diastolic diameter was 6.4 centimeters. Can't really appreciate it here, but there's actually a thrombus up here in the right ventricle that gave us a little bit of consternation, a large moderator band. So she is being evaluated for heart transplant. We did a right heart catheterization. This was done at a time that she was optimized on medical therapy. She was being maintained on milrinone. You can see there that she had very low filling pressures, an RA of 3, a PA of 30/12, and a mean of 18. Her wedge pressure was reduced effectively down to 14. She had a cardiac output of 4 liters per minute. but she was hypotensive with a blood pressure of 81/60 and a mean pressure of 67. So we completed our evaluation. We thought that she was an appropriate candidate for transplant, and she was listed for transplant. And after a couple weeks of discussions, she decided that she agreed with us, and the best way for her to be bridged to transplant, the safest way would be with a durable mechanical circulatory support device. So Dr. Anyanwu implanted the device using a lesser invasive approach, and she was discharged home on postoperative day 10. So maybe, Ani, for those in the audience who are less familiar with this, can you just describe what you mean by a lesser invasive approach, and why would you choose to implant it that way as opposed to a median sternotomy?
No, it's just techniques that avoid stenotomy. So basically, they involve either a left thoracotomy or left subcostal incision, and either a right mini thoracotomy or an upper hemistenotomy incision. In her case, she had a subcostal incision and a right mini thoracotomy. The basis is really just to avoid the stenotomy and hopefully avoid the adverse injury that the stenotomy has on the right ventricle. That's the main thing.
And how do you identify the left ventricular apex when you put these pumps in? Because we're going to come back to this in a minute.
Just by imaging, by CT scanning.
When you're implanting the device, how do you?
Oh, sorry. Oh, you mean when you just look at it and there's an artery called the left anterior descending artery.
You said that like a cardiologist. Well, you just look at it and you put it in.
So can I tell you, this is really funny because I had this exact same back and forth with Chris Salerno and Yoshinaka and others. And I said, look, when you've got this big dilated spherical ventricle, how do you know that you are actually poking the apex? And they said, well, we just know. We just know exactly where it is. We feel it. You just need to go in and, you've never been in the OR. And I'm like, okay. But apparently, surgeons have a knack for identifying the apex even when it's not evident.
I mean, the truth is we don't put it in the apex. We just put it in the ventricle. So like when some surgeons will say they put it in true apex and true apex, that's all made up. You just put it in the ventricle.
Yeah.
You put it in
So as you can see, she did extremely well. She went home post-operative day 10, which is lickety split. And she had routine VAD follow-up care, really no issues whatsoever, good quality of life, highly functional New York Heart Association Class 1. And then about a year later, she started to have a phenomenon that we've seen with the HeartMate 2 device. She developed a short to shield. I won't go into all the details about this, but it's a problem with the external driveline and the wires that are carried in that driveline. We were able to maintain her with batteries and an ungrounded cable. But anyway, we decided, look, this is sort of a burning platform, and this is not a stable situation. We need to think about what the next steps are. So we repeated her echocardiogram, and this is the echocardiogram for about 20 months after VAD support. And looks a little bit different, wouldn't you say, Steve?
Yeah, so here the LV size definitely appears to be smaller. Systolic function appears better, but the RV here looks much more dilated and much more dysfunctional than before.
So Donna, how confident would you be? She says, look, I'm tired of this thing alarming. It's going to stop on me. Can I just have the pump removed? Would you do it?
Well, she fits the phenotype of the patient who would recover. She's a young person with a dilated cardiomyopathy who had a short duration of disease. I don't know if she was optimized on her oral medications at that point, but looking at that ORV, I would just be very concerned that she would develop recurrent heart failure if that didn't get better.
So I'm going to ask Dr. Mehra to comment on the RV in just a second. But so Michael, let me put you a little bit on the spot. And if you don't remember all of them, that's okay. But in your monograph, you talked about the ICARS score. So for those of you who are not familiar, there's a group out in Utah who are doing phenomenal research looking at myocardial recovery and looking at it from a very scientific approach. And they came up with a score when they looked at their experience, 6 things that seem to identify the phenotype of a person who's more likely to recover. And do you remember what those are?
Yeah, I'll try my best. I think so part of this came from looking at the Intermax registry, and they were able to identify 6 characteristics that were predictive of recovery. I think the first one, which Dr. Mancini mentioned, is non-ischemic patients are more likely to recover. 2, patients who are less dilated. So if the the left ventricular end diastolic diameter is less than 6.5. Patients who are younger, who've had heart failure for less amount of time, so less than 2 years. If their creatinine is less than 1.2, if they actually did not have an ICD, interestingly.
And you nailed it. Those were all 6.
Okay.
You got them all. Oh, well done. Yeah, so age less than 50, creatinine less than 1.2, LVEDD less than 6.5, no ICD, duration of heart failure less than 2 months, and now I forgot what the last one is too. Age, creatinine, time. And non-ischemic, yeah. So she fits almost all of those. So her LVEDD was 6.4, her creatinine was less than 1.2, she was 30-something years old. Short duration of time, it was less than 2 years for heart failure, and she only had it for 3 months. Non-ischemic clearly, and she did not have a defibrillator, although that was more just being teased out in a database. But so she really fits the profile of someone who should recover. So I'll ask you, Dr. Mehra, this heart, do you think it's recovered? And what do you think of that RV?
So is there a reason why you guys at Sinai don't use Doppler? I'd like to see how the valves are as well.
Because I put this together this afternoon, that's why.
So okay. No, and I'm making a point about whether there's any mitral regurgitation or tricuspid regurgitation as well.
Very mild, very mild.
Yeah. So okay. So let's look at this case. So it's pretty clear that the LV has improved. The septum is dysynchronous in the way in which it's moving, and the RV has actually gotten worse in this case. Now, is this recovery? Well, you brought up the whole issue of the nomenclature. I think that we should not talk about recovery as recovery. I think we need to use the R word a little differently, and I think I liked what Michael had positioned this as potentially remission. So the LV seems to have gone into remission, and I assume this is at the full speed of the HeartMate 2 right now. So right, so we don't know if the RV is actually simply responding to a high preload or not. I think the next step that I would do in this case is it's pretty clear that change has occurred. I would actually like to see invasive hemodynamics in this patient. And to see what happens to the LV and the RV and the hemodynamics with the pump turned down. And I would actually try and do a pump off study in this patient down to a speed of about 6,000 RPMs and see what happens, which I assume is what you considered doing next.
We did. We considered doing invasive hemodynamics with a pump turn down, and we also considered doing a CPET with a pump turn down. Would you transplant her if you had an offer?
Right this moment?
Yeah.
No, I would wait. Because I think this patient, 31-year-old, if I transplant this patient now, I've given her a conditional survival of about 60% at 10 years. So she has only a 60% chance of making it to the age 41. And then, of course, she could have a second transplant. On the other hand, if I can truly put her in remission and decommission this pump, I might be able to buy her several more years as long as she doesn't decide to get pregnant again.
So we decided we needed to push her medicines a little bit more. So she was on carvedilol at a reasonably good dose. We pushed that up. She was on losartan. We switched her to valsartan at a high dose, 160 twice a day. She was started on spironolactone and as well as digoxin. And with a pump turned down.
Sorry, Sean, just on the transplant, just one bit of history before this echo is that she actually did get a donor for a transplant.
Don't go there yet.
Oh, that was after? Okay, sorry.
So as we're evaluating her, we had a debate. Do we transplant her if we get an offer? This is an unstable situation. Her pump is alarming. or do we try to explant her? So 22 months after implant, she gets called in for a transplant, as Dr. Anyanwu was mentioning. And so she gets called to the hospital. She's being prepped for surgery. Let me ask you, Ani, what did you think when you went to go operate on her? Before we get to what happened with the donor, I mean, were you confident that you were doing the right thing?
Yeah, because the echo that you showed, I wasn't privy to that echo before the day of transplant. So I think it came after the transplant because we put her to sleep to do a heart transplant. And anesthesiologist did a transesophageal echo and said, why is this patient in the operating room? And looking at the echo, even with a turn down, the ejection fraction was about 60% with a turn down under anesthesia in the operating room. The right ventricle wasn't good. So then we started having concern.
So quite literally what happened was a donor coordinator at the donor hospital claimed that they saw the donor cough. And they said, maybe they're not brain dead. And so they called the whole thing off. Seriously. And so after that, and hearing what happened in our operating room, we decided to take another look at recovery. So this is with device speed turned down. This is at 6,000 RPM, so that's a nominal speed. So at that point in time, the pump is still spinning, but there's no net flow across that impeller. So this is the heart fully loaded, and this is what the echo shows. So I don't know, Steve, can you just walk us through this?
So I think somewhat similarly to the one echo that you showed before, the LV function is better than the very first, but maybe not quite as good as the second one. The RV on this one does not look to be as dilated, but still looks dysfunctional. In the echo lab at Sinai, we charge extra for color Doppler, so we don't have those here.
So she was being set up for pump exchange based on that echo at the turn down speed. I'll tell you, she also had a CPAT that was favorable, and her hemodynamics, her resting hemodynamics were favorable. And as we were getting ready to exchange the pump, she developed red heart alarm. So this basically means that the pump is stopping. And so there was a choice. You could either exchange the pump, take the one that's broken out, put a new one in, or just take the LVAD out and hope that she does well with her recovered heart. And so after informed decision, informed decision making, she wanted to have the LVAD removed and not replaced. And that was done performed through a left subcostal incision and a mini thoracotomy at the fifth intercostal space. The pump was removed, and then I think, Ani, you left the outflow graft in place, but it was ligated or stapled, one or the other, yeah. And she went home 9 days later. Since that time, she's been maintained on carvedilol, losartan, now depending on which one has cancer-causing drugs or not. I think she's on some other ARB, and we're switching her over to Entresto, and she's on spironolactone. So, Michael, you mentioned it very quickly in your comments. You just want to talk about TREAD-HF a little bit more?
Yeah, so it's a pretty small, I think, single center study that was done in the UK. And they looked at patients who recovered their ejection fraction and were on optimal goal-directed medical therapy. So they were on beta blockers, ACE or ARBs, and Bactone. And what they did was in a stepwise protocol, they de-escalated therapy. So I think they took away the spironolactone first, and then a beta blocker, and I think finally an ACE inhibitor. And then they followed them prospectively. So that was the intervention arm, then there was a control arm. And when they compared the two groups, they found that the patients that had de-escalation of their medical therapy, they actually had a significant drop in their ejection fraction, and they had worse outcomes at 6 months. So I think what they then did was then reintroduce the therapy, and for the most part, the patients did well, but I think it demonstrated that when patients have their therapy removed, they're not necessarily recovered fully or cured, but more so in probably a state of remission.
Great. So let me just show you, this is her echo a year and a half later, which was just from a few months ago. What do you think, Steve, about 45%?
Yeah. I think 45 maybe. with some contrast, might be able to get a little bit better sense of the endocardial border. But the RV does not appear big again. It looks like maybe mildly or moderately increased, but overall function is maybe, yeah, as you said, maybe 45.
So I think this case highlights a lot of the themes that we're going to talk about in the next few minutes as we dive a little bit deeper, but a real-life example of potential myocardial reverse remodeling versus remission versus recovery. So I chose those words very deliberately: reverse remodeling, remission, recovery. So Mandeep, tell me a little bit more about your thoughts about whether or not true recovery occurs, and should we be using the term remission instead?
Yeah. So I think first we should understand that there are multiple terminologies, and all of them might be true in certain scenarios. So by definition, recovery means a restoration to the original normal state in the absence of requiring any intervention. So that's recovery. So this would have been recovered if the patient was not on losartan, not on carvedilol, not on diuretics or whatever, and the ejection fraction, biventricular function had normalized. That would be true recovery. Remission would be where the patient has simply moved to a slightly different stage of the disease. And if you think about this, the way I like to look at this is actually a schematic that was initially proposed by Doug Mann and Dan Burkhoff in a paper in 2012 on this issue in JACC, where they actually looked at biomechanical engineering principles, and tried to give a construct of how to differentiate the two. And they actually used the terms of elasticity and plasticity as being two gradients of abnormality of any substance. So what's the difference? An elasticity is like a rubber band. So if you pull on a rubber band and you release it, then the rubber band goes right back to its original state. None of the atomic bonds in the material there were disrupted. They were stretched, pulled, but they weren't broken. Or you take a clip, a paper clip, and you actually pull it, or you take a coat hanger and you bend the coat hanger. Well, at that point, if you've bent the metal, if you try to straighten it back, there will actually be some gaps or some, it won't be a perfect straight line, and it won't return back to its state. That means that it has some form of deformation in it. It may have been restored back, but it remains deformed because there actually has been atomic bond breakage. And that is a form of plasticity. And I think that what we are observing in the heart is that in some situations there is elasticity, and in most situations there is plasticity. And that there is a change of deformation back to a state which is still not normal, as in this case, where the bonds actually form back enough to give support, but never to completely normalize, as in this case. So examples of elasticity of the heart. Takotsubo cardiomyopathy is an example where you'll see an acute insult and then the heart completely normalizes within a few days, and you don't necessarily need medications to continue. Or if you have an energetic-induced cardiomyopathy, tachycardia-induced cardiomyopathy is a classic example of that. Or in some cases, some toxic exposure may in fact also allow you, like alcohol. Acute alcohol use will diminish the cardiac function. Then as you withdraw it, the cardiac function completely normalizes back. So in those cases, I think there is clear elasticity. And in those cases, there is true recovery. In most other cases, there is actually remission, or as I call it, persistent deformation. So that's how I like to think through these.
And if we think about those deformations, and by the way, I heard Doug Mann talk about this. He used the example of a slinky. A slinky. Remember slinkies that would go down the stairs? Same thing, I don't know. If you're of my age, I guess you remember these things. Metal thing, and you twist it one day, and you never get it right back. It never goes back. And so if we think about what those deformations are, what are they in the course of developing heart failure? We saw some ultrastructural evidence of that with, changes in myocyte structure, as well as changes in extracellular composition, not only the density of the extracellular fibers, but also the type of collagen that is laid down. But when we go a little bit deeper too, if we look at gene expression profiling, there are abnormalities there too. One of the things that have come up though, and maybe Don, I'll ask you, when we talk about trying to recover these hearts, we put everyone on neurohormonal antagonists. Is that because we're actually affecting a change, or is it just because that's what we do as heart failure doctors?
Well, I think the evidence that we have, this person probably has class 1 heart failure. And there's evidence-based medicine that patients who are treated with ACE inhibitors and beta blockers have a decrease in heart failure development and hospitalizations. So I don't think it's just that we're, treating ourselves. I think we're really trying to prevent the disease from progressing. So I think we're actually impacting it.
So Noah, as you know, the Utah group has published quite a bit, and they've looked at their own experience. We can talk a little bit about restage HF. We'll do that in a minute. But one of the things that Dr. Stavros Drakos, who is an eminent researcher in this area of recovery, has said many, many times, which is that you only find the things that you look for. And if you're not looking for recovery, it might go right underneath your nose. And one of the ways to facilitate recovery is to treat people like you want to recover them. Should everyone who gets an LVAD, who has presumably a non-ischemic cardiomyopathy, we'll keep it clean and just say non-ischemic cardiomyopathy, should everyone be put on a recovery pathway?
I think whether you're using the medicines as a recovery pathway or to treat their existing myopathy, patients with LVAD still have a myopathy behind the LVAD. They still have RV dysfunction, which we've spoken about earlier, but they also have other issues with their heart still. So I think either way, it's probably the best treatment for them. How aggressive to be, I think that's maybe where a recovery pathway would be helpful for certain patients. And perhaps using, I think not all patients would qualify for it, but perhaps using something like the UCARD score to guide who you should be very aggressive about, because it takes a lot of work to get these patients on optimal therapy and pushing the therapy and convincing the patients the reason to push the therapies, which we discussed before too. So the answer is I think everyone should be on neurohormonal antagonists if they can tolerate it and if there's no contraindication for both reasons, but a recovery pathway is something probably dedicated to a certain phenotype of patients.
So one of the things that neurohormonal blockers do is obviously they block the response to the heart being dilated, to that increase in wall stress, which becomes a consistent trigger for neurohormonal activation. What we're trying to do is block the response. But if you go a little bit deeper into recovery, one of the reasons why I think there is such an enthusiasm for studying these patients, and each person could be their own laboratory, is the fact that we may be focusing on the wrong target. And that is that there may actually be specific pathways that get activated that lead to recovery that are separate than the pathways that we currently try to block by giving neurohormonal antagonists. And so, Donna, one of the things I remember, literally, I was a first-year fellow, moonlighting at the Allen, and I read a case series that you published about myocardial recovery in a handful of patients treated with the HeartMate XVE at Columbia. Can you just talk about that experience, and then I'm going to come back to the point I was making before about activating other pathways.
Well, one of the first reports of the low recovery rate in the LVAD patients was from a series at Columbia where maybe around 5% of the patients were recovered and explanted. But the problem that we had with the patients who were explanted was that there was a rapid deterioration in LV dysfunction. And so, it's not only a question of recovering the heart, but it's a question of trying to predict the durability of the recovery of the heart. And then after that initial report, then we did the working group recovery series with Simon and We had multiple institutions where we looked at around 70 patients, and only around 10% of the patients recovered. So the problems with both the Columbia series as well as with the working cardiology group series was that we did not mandate a regimen, a medical regimen for these patients to be on. And I think that it really is important for these patients to be on a good heart failure regimen, because I think in order for them to be able to function better, not only to recover, but to function better, they need to be maintained on heart failure medications.
And so when there was a report in the New England Journal by Emma Burks and the Harefield group, they looked at 11 patients that had high rates of recovery. Almost 80% of those patients recovered enough that they could have their LVAD explanted. And they were on high-dose guideline-directed medical therapy, high-dose beta blockers, high-dose ACE inhibitor, plus an ARB, plus spironolactone, plus digoxin. Amazing that these patients were able to tolerate the doses of these medicines. But there's one other medicine. Plus clenbuterol. And so, Donna, what is clenbuterol? And you want to talk us through, because that gets into what I was saying about, it's not just enough to block the pathways that are activated, but it's also something that we may need to stimulate these hearts if we want to get them to recover.
It's a beta-2 agonist that induces hypertrophy, which I really could not understand, because there's no myocardial atrophy in these patients. These patients still have a lot of hypertrophy. So the reason why this additional drug was added in didn't really make a lot of sense to me.
So I think that the only way you can get clenbuterol, they were using it in racehorses to improve their performance, and I think some of the Russian doping was using clenbuterol at one point as a performance-enhancing drug, and you cannot get it in the United States. So Restage Heart Failure was essentially that research group, Dr. Emma Burks, who is now down in Kentucky, Louisville, Kentucky, plus the group at Utah. And they stayed with the medical therapy, so carvedilol 25 milligrams twice a day, lisinopril 40 milligrams once a day, plus losartan. I think the dose was somewhere between 50 or 100 milligrams a day, plus spironolactone between 25 and 50 milligrams a day, plus digoxin. So really throwing the kitchen sink at them, but without clenbuterol. And so, Michael, what did they show in Restage? Do you remember?
So I guess foremost, the patient population in that study was probably different than what we normally see in clinical practice. They tended to be younger, and they're all non-ischemic patients who had recent onset heart failure. But the outcomes were quite remarkable, and about 50% of patients actually recovered on that regimen.
So there were, yeah, Dr. Lala.
It's a question for Dr. Mehra. Why do you think that hasn't been published yet?
Okay, so some details of Restage. So Restage was a 6-center study that enrolled 40 patients over a large number of years. It took them a long time to enroll patients from these 6 centers. The premise was to take non-ischemics with less than 60 years of age, those patients who on the score would be. So question number 1 that I would have for Michael is, Michael, do you remember the average age of the patients enrolled in Restage?
I think looking at the abstract, it was around 35 years old.
Correct. Very good. So it was 34. So the average age of the patients was about 30 and not older, not closer to 60. Second interesting issue is that when you look at these patients, almost all of them had heart failure within about a year of enrollment. 1.2 years was the average duration of heart failure, as opposed to prior trials. Third is that I think if you really look by intention to treat on the 40 patients, the actual explantable recovery rate was 37.5%, not 50%. And what that basically means is that in a population of 30-year-old patients with non-ischemic cardiomyopathy and recent onset heart failure, 1/3 of these patients were able to be quote-unquote recovered to the point of explantation. Now, when you look at that is identical to what is observed in myocarditis. without LVAD support. 1/3 of patients get better. That is identical to what is observed in peripartum cardiomyopathy. 1/3 get better, 1/3 stay the same, 1/3 get worse. So I think that what was observed in restage had very little to do with the LVAD and its facilitated hemodynamic unloading, maybe a little, but it had everything to do with the intended pathway of expectation of the patient population enrolled, is the way I would look at it. Now, having said that, I don't mean to criticize the trial in a profoundly negative way, because until such trials are actually done, we won't move the field forward. And they do keep the principle, in my opinion, of so-called remission with LVAD-supported facilitation alive in many ways. But I think, you draw parallels of restage to TREAD-HF, very similar number of patients, and you kind of reach the same situation. TREAD-HF actually, to just come back to that for a minute, had two very interesting things. They actually genotyped these patients with biopsies, and they looked for titin mutations in these patients. And all patients underwent CMR, CMR in TREAD-HF. And what was interesting is that despite full so-called recovery, where the LVs and RV looked normal, the NT-proBNP expression was nearly normalized to an NT-proBNP less than 250, where the patient became NYHA class 1, 42% of patients continued to have late gadolinium enhancement with patchy fibrosis on CMR. And many of the patients had titin mutations, indicating that some were familial and were destined to have problems. In the trial, they were unable to correlate those two findings with whether somebody recovered or not. And if you're the person with the glass half empty versus the glass half full, you can look at TREAD-HF in two different ways. You can say, look, if I'm an optimist, I would try that in everyone and get away with it 50% of the time. On the other hand, if not, then 50% of them would get worse and get rehospitalized and worsen their heart failure. So I think we have to take restage and TREAD all with a grain of salt. And I think that I don't see the results of restage as being as remarkable as they have been sold.
I just would like to say that I'm not an optimistic person at all. I tend to be very pessimistic. But I have to say that restage, you're not giving it enough credit, because a lot of those patients, especially some of them that come in crashing and burning, they would have died without LVAD support. And then you have the luxury of time to introduce the medicines. And the other thing that Mike doesn't probably know about is HARPs. You remember HARPs?
Yep, I do.
Remember HARPs.
So I think what Dr. Mancini is mentioning is that after the Harefield experience was published in the New England, a replication trial was attempted in the United States called the HARPS trial. Now, they allowed entry of ischemic and non-ischemic patients, and multiple centers got together, and basically they enrolled a few patients, and one patient was explantable and recovered over, I don't really know how long it was. The trial remains unpublished, 4
Right.
years, or
They never published it. It was a bust.
Right.
And, basically it was because they didn't have this cherry-picked population.
Right. And so I think the bottom line is that, again, like I said, there is a population that has reasonable elasticity with little plasticity, and then there's the population that has a lot of plasticity with very little elasticity, and picking those up is the key. So to actually move that concept slightly forward, again, a classic example is the COAPT trial versus MITRA-FR. Classic. So if you actually consider those trials as trials of recovery, forget that they were trials of mitral regurgitation. If they're trials of recovery, what is pretty clear is that the population that ended up being enrolled in COAPT after a lot of push was slightly more elastic than plastic, and in MITRA-FR was slightly more plastic than elastic, and that's why you have those discordant results. And intriguing way to look at it. Well, the way I think about it is restage, to give credit to the Utah group and to give credit to all the investigators that are continuing to keep the mantle of so-called recovery alive. I think that there is a recoverable population. I think that it's a very tiny population. If you think about generalizability of restage, over the last 4 years, how many patients with that profile have you seen at Sinai? An average age of 30 with recent onset of heart failure, that needed a VAD. And what you might find is maybe 2, 3, 4, something like that. It'll be on single, you'll actually pick them up as very few. So I think that's one of the key challenges in the field is how do you pick these patients? There is a field, but to try and apply something like this on a track where you over-apply the technology. So it's another analogy would be, what if you just went ahead and started repairing mitral valves like crazy, despite these dichotomous trials? I don't think that would be wise. And I think the same thing is true with answering the question you actually posed at the beginning, which we haven't answered and we hope to answer, is that once you place a VAD, should everybody be on a recovery pathway? I'm not so sure that that's true.
I would agree, and I don't think that we place very many patients on a recovery pathway here, except in those patients who we would think have a high probability of recovery. Yeah.
But what is the difference between a recovery pathway and treating them with heart failure medicines?
Nothing.
Right.
No, I think the recovery pathway is the one where you treat them with heart failure medicines, but then have a very structured approach to evaluating improvement in cardiac function, either invasively with invasive CPAT or other techniques. And I think that's the difference, is how much monetary value, if you will, and resources do you invest in this? So for example, ramp studies. If you really see, the ramp studies were recommended from the Columbia group, and I think we overdid these studies. I think we didn't know what we were doing with them. So the only point to make is that as we think about otherwise good techniques of surveillance of patients, that we should be careful in not overusing them. The same is true with heart transplantation. Why do we do biopsies with the frequency we do? It's crazy because somebody starts and it seems to have is associated with reasonable outcome, and so everyone uses it. So I think we have to be careful.
I think, don't you think that the field of myocardial recovery is valuable because it gives us a window, a molecular microscope to try to understand the pathophysiology of what's happening? And that's really what Dracos and the Utah people are trying to do.
I completely agree. I completely agree that the VAD population gives us the best translational capability of understanding the pathways. But I think we need to identify in a very structured way what those are and how we're going to investigate that. So we were making fun about the apex issue, but I was making the point at Grand Rounds this afternoon that if you actually core out the apex is fundamentally one of the most important mechanical efficiency imparting anatomical regions of the left ventricle or the heart itself, and that allows it to actually twist, allows it to actually perform in a mechanically efficient way. That's a big problem. When we put in an LVAD, what happens to coronary blood flow? We pay no attention whatsoever to coronary blood flow. We did a study, our fellows did a study a few years ago where we looked at non-ischemic patients, and then we just randomly went to our readers, and we had done with the pump down and pump speed up, and we went to a panel of readers and said, identify who's ischemic and who's non-ischemic, and they couldn't identify the difference. Everybody looked ischemic, even though they were non-ischemic patients. And so there's a difference in coronary blood flow in these patients. We have no idea. The RV, you saw what happened in this case, a unique situation. The RV was dilated while the LV had recovered, and then the RV improved as the preload to the RV decreased after the VAD speed was put down, which is remarkable, right? So there's so much to be learned on how to assess the RV, how to assess coronary blood flow, whether we are implanting these devices correctly. So a structured approach needs to be taken to this, is my, my strong feeling.
And then along those lines, Dr. Anyanwu, do you think it matters how we program the pumps? Should we be altering pump speed? Should we be trying to load these hearts at different intervals?
I think it's one of the things we just don't know.
Yeah.
I think anyone who has an answer to that question, they're just making it up. It's as you
Dr.
say,
Mehra?
years ago, everybody wanted to do a ramp study, but the reality is no one knew what the information that we obtained meant and what to do with it.
So I'm going to make up an answer as you suggested, and one reason to consider differential pump speeds is in an attempt to maintain normal aortic valve function, and so we don't know the answer to this, and I would be the first to actually make that statement. But I would like to not allow the aortic valve raphe to fuse. So if you actually increase the dose of the pump speed excessively to the point where the aortic valve is persistently closed, then about 50% of those patients at transplantation, at least in our series, because from listing to transplantation for us at the Brigham is about over a year to 2 years, we'll actually find the raphe are fused in over half of these patients. And how that translates into the new epidemiology of aortic insufficiency with these patients, which too, I will argue, is not conducive to recovery, is another area that needs to be directionally identified and dealt with.
Well, I know that Dr. Mehra has to catch a train, but I didn't want to let him leave before I opened up to questions. Yes?
And when the device was explanted, did you take that opportunity to get tissue? I think in situations like that, it would be very valuable to get tissue from AR.
So it's a fantastic point. So the question was, when we explanted the valve, did we also take tissue? And I think all of these patients, whether they're explanted or when they're transplanted, to have that ability to compare the before samples and the after samples is an opportunity that if we're not taking advantage of it, it's an opportunity lost. But I don't remember, Ani, if you biopsied. I don't think you did.
I mean, because we're doing it through a minimally invasive approach, so we can't see anything other than the apex, and the apical region is scarred because that's where the device was, so the tissue there wouldn't be helpful. But if we really wanted to do that, we could have biopsied the septum, so it's something that we could do in future if it's going to be helpful.
Yeah.
I think the Utah group is doing it in a systemic manner, so they're going to analyze before, after, right? With genetics.
And I'd love to see CMR on this patient now.
So time didn't allow, but we did a CMR before the VAD went in. She had a little bit of delayed hyperenhancement in the mid-myocardial stripe in the septum. And then following her explant, we repeated the cardiac MRI. We saw no delayed hyperenhancement, and there was no scar except at the LV apex.
So you didn't put a defibrillator in this patient. Is that something that, Mandeep, what do you think patients like this, if you recover them, should they get a defibrillator?
Oh, no. I wouldn't have put a defibrillator. You mean now?
Post LVAD removal.
Post LVAD removal? No, typically not if the ejection fraction. We would just use the same criteria for ICD, prophylactic ICD implantation as we do for anyone else with an EF of less than 30%, et cetera. But I think in this case, we would not have put in a defibrillator.
I know when I was at Harefield in the original New England Journal paper, one of those patients that died was like a 20-something-year-old. 2 weeks later, just went into ventricular fibrillation and died, just out of the blue.
Yeah.
Post-VAD implants, and he had normal function, in quotes, systolic.
You don't worry about that big score from the big score that they have from the removal of the LVAD?
The what, I'm sorry?
The big score at the apex that they have from removal of the LVAD?
Yeah, so I think the question that you're asking is that scar in the LV a nidus for reentry, right? Yeah, and how often will that come? So I would say I don't know if that's still sufficient reason for me to go in and put in a ICD, because we have so many people with heart failure walking around with EFs in the 40s and with scar. Now, it might be more diffuse, and not necessarily scar, or we have people with scar otherwise that might have a ejection fraction in the 40s that may not ever have an arrhythmic event. Would you have put in would you just put in an ICD in these patients, young 31-year-old?
I guess I would be concerned, especially in the perioperative period where I didn't know where the trajectory was going to go, whether the patient was going to reverse remodel again and develop heart failure. So maybe I would have put her on amiodarone to protect her a little while.
I would personally be more concerned that apical area with scar might be a nidus for clotting and thrombus in the future. And then the other question that comes is, should you actually have her on anticoagulation, even though she's in sinus rhythm?
Is she on aspirin now?
No, I don't believe so. No, I don't think she's on any anticoagulation or antiplatelet agent. She did go home with a life vest for 3 months. She had no events, and she took it off. Eric?
I wonder if we're giving ourselves too much credit or something too much credit for recovery. I'm thinking about our nephrology colleagues who the autobiology has made reserve so that the kidneys can hyperfilter and the numbers look wonderful. Like the EF looks wonderful, but what you've lost is the reserve, and we don't have a good way to test that. So before you say they recovered, and as you, I think, correctly said, recovery means you're back to normal before anything bad ever happened, I doubt that actually occurs with, I think it'd be unusual. If you don't lose any ultrastructural stuff, fine. I suspect that we lose it pretty often, and you never come back totally to normal. And as you're saying, if you find titin mutations, it's only a matter of time. So. Just a thought about we're measuring it because we can, but I don't think it's the right thing to measure, just like ejection fraction, as Sean has said over the years, and others as well.
Yeah, and I think you make a great point that resting hemodynamics in these patients may be illusionary, and that you do need to see evidence of reserve. And that's why, our practice in some of these selected cases is to do an invasive CPAT with the VAD turned down all the way to see how much reserve they have. Even then, with this thing sitting in the apex, there's already loss of lusitropic function. Yeah, people don't realize it, but the diastology of these ventricles is very aberrant. It's not just the systolic component. So.
Yeah, we have the unique opportunity with Dr. Moss and Dr. Mancini to do these invasive hemodynamics combined with cardiopulmonary stress testing, which is we're really lucky to have that. Yes.
When I look at this echocardiogram and the echocardiogram you showed earlier, and I think of the myocyte, the vascularity, and so forth that changed between the previous echo and this, do we really know what's happening?
No. And I think that the challenge is that what we need to measure, we cannot measure, but we measure what we can measure. And I think we have to combine not only the geographic imaging that we get with echo with some functional test like a cardiopulmonary stress test and the invasive hemodynamics to try to come up with a composite picture. But the other things that we need to see, we can't measure. The gene expression profiling, the microRNA expression, the composition of the extracellular matrix, et cetera, et cetera.
Yeah, I think that we'll never know the exact answer, and we'll never have the right biological interface to make these decisions, as you correctly pointed out. I think that just like in medicine in general, we're going to have to rest ourselves on this notion of NNT, number needed to treat versus number needed to harm. And that may be a useful construct to think about even as we are thinking about the remission/recovery space, is to say, okay, how much are we willing to sacrifice, going into this notion? And I think that construct would be far more valuable to get us to a reasonable place, because no medicine works 100% of the time, and no device works 100% of the time.
Well, once again, I'd like to thank Dr. Mehra and the panelists for a wonderful discussion this evening. Thanks so much.